Good
We are
evening,
live,
everyone.
doctor.
Good evening, everyone. I'm Dr. Rajeshwari, Clinical Head and Fertility Specialist, Oasis Fertility, Bengaluru. Today, I'm here to discuss the topic called Unexplained Infertility. Unexplained infertility is a very frustrating diagnosis for all the couple. So I will try to make it as simple as possible to understand what is the reason and how to go about. Before I go in with the topic, I just want to tell briefly about menstruation, how the egg is released, and how fertilization happens. I'm sure all of you know, but I thought it will be relevant for my topic to tell about this initially. This is a small diagram telling about this is the vagina, cervix, uterus, and the two tubes on either sides of the uterus. These are the ovaries. Egg is released and the fallopian tube picks up the egg. At the time of ovulation, when you have intercourse, semen is deposited in the vagina here, and the sperms travel the cervix, uterus, and go and find the egg in the fallopian tube, fertilize, and form an embryo. Once the embryo is formed, the embryo travels into the uterus, comes and implants or sticks there and grows as a baby. This is the normal anatomy. Normally, when you have periods, if you have a 28-day cycle, around the 14th day is when the ovulation happens. And for a woman who has a 28-day cycle, she can predict her ovulation and can have intercourse during that time. Sometimes women may have a longer cycle or a shorter cycle, say about 21 to 35 days. For them, we say from 10th day of your menstrual cycle to about 20th day, if you have intercourse at least alternate days or once in 2 days, chances of fertilization or becoming pregnant is high. When we tell a couple to have intercourse and on the day of the ovulation, it may be very frustrating, and they are so stressed and they will not be able to perform. So as the sperm are in good condition for 48 to 72 hours in the female genital tract, we advise the couple to have at least on alternate days or once in 2 days to increase the chances of pregnancy. So when the women are trying, or when the couple are trying for pregnancy without any contraceptive measures and regularly having intercourse, 80% of them will conceive within 1 year. And the remaining 10%, that is a total of 90% of them, will conceive by the end of 2 years. So just telling what is infertility. Infertility is inability to conceive after 12 months of unprotected and regular intercourse. So what is this, statistics, if you have to tell, 1 in 7 couple are facing the difficulty in conception at the end of 12 months. And the studies are showing that there is increase in the number of couples who are coming into the clinic for fertility issues. That may be because of the stress, or they may be becoming aware of the fertility issues. One thing because of education. Another thing may be because of the environment pollution. Everything may be contributing to this increase in the. I'm just trying to increase the slide share. Increase in the awareness and fertility issues, people coming for the fertility clinic. Among the causes which are giving rise to infertility, I've just put one small pie chart so that we can understand. There is 30% of the cases exclusively problem may be found in the women. And in 30% of the couple, there may be problem only in the men. And in 10%, there can be some problem in the men and some problem in the women as well. And there's a big share, that is 25 to 30% of them will be unexplained infertility. I'll come to what is unexplained infertility, definition, and how we are going to go about. And there are about 5% other causes, that is other than men, women, or combined causes. It can be some systemic problems which may be giving rise to this fertility issues. A couple who are trying for pregnancy, when should they see the doctor is a question. See, if they have tried for 12 months without any contraceptive device, and regularly. They are aware of their fertility time and they're trying it regularly. Another second one is the women are over 35 years of age at the time of marriage and they have tried for 6 months. Or the woman has had previously some surgery over the uterus, say for about, for example, endometriosis, or she has had a previous ectopic, or she has had some fibroids which has been removed through surgery. Why we are particularly saying this? One thing is after the pelvic surgery, there are chances that there can be adhesions and difficulty in conception because the tubes may be pulled away because of adhesions away from the ovary, or the ovary might have gone and stuck behind the uterus, where the normal tubo-ovarian anatomy may be distorted. That time also they may have difficulty in conception, so they should come a little early because there is a known cause, and we may treat it at the earliest rather than leaving it or waiting for 1 or 2 years and then trying. Now coming to that, what is unexplained infertility? Unexplained infertility is when there is, after you do the regular investigations, there is no obvious treatable cause is identified in the either of them, either the man or the women. So that actually when you do the test, they are ovulating. Evidence of ovulation is there. When we do the HST to test the tubes, tube is open. And the semen parameters, when we check on the man, the semen parameters, the sperm number, quantity, and motility, morphology, everything is fine. There is no obvious. Everything, when we do it grossly, that everything looks fine. So if everything looks fine, then where is the problem? Why are we calling it as unexplained? Because it is at the microscopic level. That's the problem, microscopic level. Maybe there is a cervical factor, immunological factor, where the adequate number of sperm may not be going and reaching the uterus or the egg through the uterus. The large number of sperms may be destroyed at the cervical level itself. Another thing can be the egg may be having a very hard zona where the sperm cannot penetrate that zona and go inside. That also may be one of the factors which may be preventing pregnancy or delaying the pregnancy. Or the endometrium may not be receptive. The endometrium may not be letting that embryo to come and stick or implant and grow. So there may be problems at the microscopic level. But grossly, we are not able to identify with the simple test what we are doing. Now coming to the couple who are coming to the fertility specialist, how are we going to evaluate them? We need to evaluate both of the husband and the wife simultaneously, because we should not be putting only the point on a woman saying that there may be problems in women only. There can be problems in man also. So simultaneously we will be investigating. If at all there is anything, we can treat and go forward. How are we going to go about? First is the history. A very good history is very important to go forward in the case. A good history both for the man, from a man and from the woman's side. For a woman, what are history, examination and investigation? Coming to the history. For a female, what are we going to ask? First, we are going to start with her BMI identity, that is height, weight, and finding what is the BMI. Even obesity can have effect on the fertility. So we have to see what is her BMI. Then coming to her menstrual history. It is very important to find out what is her menstrual history like. Is she getting regular 28 to 30 days, or is it irregular? Whether she is getting only withdrawal bleeding. What we assume is, if a woman is getting regular periods, most probably she's ovulating, is one thing. Second thing we want to know is, has she had any prior pregnancies? Maybe from the same marriage or from a different, but whether she has had a previous pregnancy. So then coming to any previous pelvic surgeries, like what I mentioned previously, for endometriosis, it can be for ectopic pregnancy, it can be, or for any fibroids, any pelvic surgery she has undergone, or history of any pelvic infections is also very important. And coming to the man, for a man, what we have to, again, paternity, whether he has had previous, fathered any children, and whether he has had any history of undescended testes, and whether they are having any problem in the intercourse, ejection or erectile or ejaculatory dysfunction. Another thing is we need to know how frequently this couple are having intercourse. because both of them will be working, and they may be working at different shifts, and they are tired from morning at 7 o'clock or so. They leave the house, come back around 11 o'clock or 12 o'clock in the night, and both of them are tired and they have no time for having intercourse. So they may not be having intercourse at all. So this intercourse history, frequency, and whether there's any problem is a very, very crucial one to in workup of the couple with infertility, because most of them may not be having regular intercourse. They may not be aware of the fertile period. Another thing is they may not be able to have a normal intercourse at all. Many of them don't even come openly to the doctor. They may just come saying that we are having difficulty. Only when we go into this, their intercourse history will be identified that they are having problem having intercourse, and that is the main reason why they are not able to conceive. Just by correcting or counseling and reassuring them, it can be corrected most of the time, and they can achieve a pregnancy without any further treatment. And it's also important to know the medical and surgical history of a man if he is on any treatment, which can have effect on his erectile or ejaculatory dysfunction or on the semen parameters. Once the history is done for both, coming to examination. Examination also needs to be done for both, for the female and the male. In female, we start from head to toe slowly. That is, one is the thyroid. We need to see for the thyroid any swelling, because when there is thyroid hormone, if it goes up and down also, it can have influence or it can have effect on the follicular development, that is egg development and releasing. So when there is no egg development and release, there can be difficulty in conceiving, irregular periods, and conception can be difficult. And coming to the breast, we need to examine for any discharge. There can be, when there is discharge, there can be, if not necessary only when there is discharge, this prolactin hormone can go up and down, but we need to see for any discharge. When there is discharge and the prolactin hormone is going up and down, that also can have effect on the follicular development or the egg development. Then we had to do physical examination, that is the pelvic examination of the women, to see if there is any. That one is speculum examination, that is to see for the vagina and the mouth of the uterus in evidence of any infection is there. And when we do this pelvic examination, Byron examination or the speculum examination, we can come to know, even if the couple have not revealed to us they are unable to have intercourse, we can identify whether they are having regular or proper intercourse for the women. Then coming to the man also has to see a andrologist for physical examination if there is any problem in the intercourse. That he needs to have a testicular examination for the size. Sometimes there may be undescended testes, so they have to, for the examination, testicular examination, and varicocele examination. These varicoceles are the dilated veins which are seen in the scrotum. Due to that dilated veins, there is increased blood flow. It can increase the temperature around the testis, where the spermatogenesis or the production of the sperm is happening. This raised heat can have effect on the sperm parameters, that is the motility, production and motility count, and motility can be hampered because of this varicocele. Then coming to the tests. What are the tests you want to do? One in the women is the basic ultrasound. What do you want to see in an ultrasound? In ultrasound, we see for the uterus. This is the uterus. We see for the uterus, and we see for any evidence. How is the shape and the size of the uterus? Any evidence of septum, or is it bicornuate? Means to say the uterus can be split. Uterus usually develops from both the sides, come and unite in the center and develops into a single uterus. Sometimes only one half will be developed, that we call it as unicornuate uterus. And sometimes both are developed, both the sides uterus is developed, but they don't unite. It doesn't unite in the center. They remain as two halves separately. That is called as bicornuate uterus. And so we can know all that. And any fibroids also can be known. Then ovaries, both the ovaries on the either side, how are the ovaries? As is there adequate egg reserve? That is, we see for antral follicular count. That will give us a gross idea whether the egg reserve is adequate or not. And normally when we do a regular scan, 2D scan, we will not be able to see the tubes. We'll be able to see it only when there is infection and it is filled with fluid, wherein it will be dilated. That's only when we say that the tubes are dilated or hydrosalpinx. That can be due to any infection that dilatation can happen. And then another test for the women is to check for whether the tubes are open. I'll just explain in a minute about the HSC, how we do it. Another thing is hysterolaparoscopy. Hysterolaparoscopy is not done for everyone, only for selected. It is reserved for selected cases. That is, you have a suspicion in her history, or there is on examination you feel there is something. Only for those cases, this hysterolab is reserved, not regularly for all women who are coming for infertility purpose or who are having unexplained infertility. This is to identify that endometriosis or any adhesion. Sometimes previous surgery or any infection can cause adhesions. As already I told, that tube can be pulled away from the uterus, from the ovary, sorry, or the ovary may be stuck behind the uterus or anywhere else, and that anatomy will be distorted. Egg is released, the tube has to pick up that egg and wait for the sperm to come and fertilize in the tube. And once the embryo is formed, it travels into the uterus. So that may be distorted and it may not happen. So when we do this hysterolab, when we suspect and we do it, we try to identify if there is any adhesions or we see any minimal endometriosis, which will not be seen on ultrasound. Ultrasound cannot identify minimal endometriosis. We can identify if you see endometriotic spots, minimal or mild, we can cauterize it and treat it as well. So it is both therapeutic as well as diagnostic hysterolaparoscopy, if at all we do. Simultaneously, we can check for the tubes as well, whether the tube is open. For any other reason, if we are doing laparoscopy, we can do it simultaneously. The tube testing also can be done simultaneously. This is the hysterosalpingogram picture. This is the X-ray. What is hysterosalpingogram? It is a radiological assessment of the uterus and the tubes. We pass a small cannula or a catheter from the cervix through the mouth of the uterus, that is mouth of the uterus, inject the dye. Once the dye is injected, radio-opaque dye that is, it fills the uterus and comes out through the tubes, and there is spillage like this. So in this X-ray, it is showing that the shape of the uterus looks normal. There is no obvious problem in the uterus, and both the tubes are seen, and spillage is also seen on either side. This is a normal HSG. I have just put a picture. I did not get one abnormal one, so I just put a picture. See, when there is tube is open, this is how it will come out and spill, and when there is block, you will not be able to see this tube. So this is an abnormal, or it is one side of the tube is blocked. And coming to the man, what investigation? We do a simple investigation, that is a semen analysis. Only if there is any problem here, do we go and do other investigations and examination on a man. Then this is the WHO recent guideline says that minimum sperm concentration should be 16 million per ml, and the progressive motility should be 30%, and the normal morphology sperm, out of 100, 4 are the minimum required normal looking sperm. So this is the recent WHO parameters which are required to be seen in semen during semen analysis. Then how are we going to go about this management? Now we have, because we haven't found any identifiable cause in a man or a woman, that is his semen parameters are normal in a man, and in a woman we have seen that uterus is normal, she has adequate egg reserve, she is ovulating, we have done a scan and we have seen that she's producing follicles and the dominance is achieved and egg is also released. And we have done a HSG and we have seen that one or both the tubes are open. So these 3 parameters, gross parameters, what we see are looking normal for us when we do the investigation. This is when we say that it is unexplained infertility. So we have come to a diagnosis now, unexplained infertility. The couple is frustrated because they are not able to find any cause. We are saying we don't have any obvious treatable cause. Then they are asking how to go about it. Since we do not know what is the exact cause, it will be empirical treatment. That is, she's producing 1 egg every month. So we want to make her produce more number of eggs, 2 or 3 eggs per month, so that we increase the chances of her becoming pregnant. So what is the initial expectant. So we found her BMI is high, means we asked her to reduce. So we asked her to reduce her coffee intake, that is caffeine intake. If she's taking too much of coffee, alcohol consumption, smoking, if all these are there, they can have certain implications on fertility. So we ask them to reduce all that. That is what expected management. Now coming to what to do, how are we going? So ovulation, ovarian stimulation and IUI is the main treatment for unexplained infertility. So how are we going to do ovulation, ovarian stimulation? It can be through the oral agents, that is oral medication. And when the egg, monitor the cycle, when the egg is ready to release, we need at least 2 or 3 eggs. The aim of this ovulation, ovarian stimulation will be to get at least 2 or 3 follicles, so that we get 2 or 3 eggs and her chances of conception increases. And we do an IUI at the time of egg releasing. When the egg is going to release, we monitor them through the scan. We ask them to come for intrauterine insemination. That is we take the semen of the man, clean it, and best and good amount of sperm are bypass the cervix. If there is cervical factor, definitely it increases their chance. Won't put it into the uterus, so that there are a more number of egg and good number of good quality motile sperms are there. The sperm are there in the uterus, so the fertilization can occur and chances of pregnancy will be there. But when we are doing ovarian stimulation, it has got its own. One is the advantage, we want more number of eggs so that her chances increases. At the same time, every treatment has got some amount of, or to say, disadvantages or risk. The same way, this also has got, ovarian stimulation has got its own risk. One risk is ovarian hyperstimulation syndrome, that is OHSS. OHSS can be controlled to a extent. It cannot be stopped once it starts. So we monitor them through scan and try to not overstimulate them. Our aim is to get 2 or 3 follicles, so that will be there. If at all she develops that, we need to appropriately manage that. Another disadvantage of this ovarian stimulation, making her get 2 or 3 follicles or 2 or 3 eggs, is multiple pregnancy, high order multiple pregnancy. Singleton, that is one baby, is what is our aim, but we cannot for sure say it will be single. It can be twins. Twins is okay. But if it becomes triplet, that has got its own disadvantages like preterm delivery. So we have to monitor very closely and try to get the stimulation and do it. If at all there is no pregnancy with this ovarian stimulation and IVF, then next will be IVF-HC. I've just put one flow chart to say how we can go about, to whom we can do how many cycles. See, coupled with unexplained infertility, no obvious treatment, no obvious cause. Now we have to make them pregnant. How are we going to make them pregnant? First, it has to be done according, what to say, we have to treat them according to their age and duration of infertility, or duration which they are trying for. If a woman is less than 35 years, that is why I'm giving that 35 years, is good number of egg reserve will be there. So I'm putting it as less than 35 years, and she's been trying for less than 2 years. Then we can we can tell them, if she's at 25 years or 30 years and just married for 1 year, we can definitely tell them to try again for a few more days for 1 or 2 more years. If that doesn't happen, then we need to do ovarian stimulation, either with the tablets or with the injection, what I get an HMG, up to 4 or 5 or maximum 6 cycles, we can try IUI. According to the evidence, they say best chances are in the first 3 cycles of IUI, but we can try for 1 or 2 more cycles as well beyond the 3rd cycle. If there is no pregnancy after 5 to 6 cycles also, then we have to move on to IVF-HC, that is intracytoplasmic sperm injection. If she is less than 35 but more than 2 years she's been trying, then we do a less number of 3 to 4 cycles of ovulation induction and IUI. Then if there's no pregnancy, we move to IVF or HC. If the woman is more than 35 years and the duration is more than 1 year that she's been trying, then for about 3 or 4 cycles, you still can try with ovulation induction and ovarian stimulation and IUI. If no pregnancy, then you have to move on to IVF-HC. If the woman is more than 40 years, then there is the best type of treatment is IVF ICSI. With this, I end my talk. If at all you have had any questions, queries, please do type your questions and we will take them. There's one question, how do I increase the conception rate in a couple with unexplained infertility? I think I have answered that question. That is the ovarian stimulation and IUI. What are the tests to be carried out for unexplained infertility treatment? I have covered that. When should I seek medical help? I've covered that. How long does it take to get pregnant with unexplained infertility? It is very hard for me to tell how long it will take for you to get pregnant. It can happen in 1 cycle, 2 cycle, or 3 cycle. That's the reason why I said best chance or the best success is in the first 3 cycles. In case there is no success in that 3 cycles, maybe if the couple are insisting, 1 or 2 more cycles you can try for IUI, or else it's better to move on to IVF or ICSI. If I have a baby once, can be infertile now? Yes, it can happen. What to say? Why I would say infertile is, one is your tubes can block anytime. Any infection can, any surgery, any infection without even surgery also can cause a blockage in the tube. Another one is the semen parameter. The semen parameter in a man keeps varying. There can be sometimes that we have done a semen analysis and he's got an excellent semen parameters, and we, for whatever reason, he has come for IUI or for IVF. On the day of the procedure, when they give a sample, they will have just 2 to 3 million. It can happen. That time we go back to the couple and try to find out whether the person has had any fever, any illness, is he on any medication all of a sudden which has been started. But without anything also, the parameters in the semen can keep changing. It keeps varying. And in a woman, tubes can block anytime for whatever reason. So with that, I think, okay, I have endometriosis. The question I'm unable to see. Just give me a minute. Okay, you have endometriosis. So endometriosis per se itself. So what can you do? Endometriosis, there are many stages. Mild, minimal, will not need anything extra. But if it is, say it is grade 3, severe, where the tubes, ovaries, all, the whole pelvis will be plastered, what we say, frozen pelvis. In such cases, you may require IVF treatment. So it's better, I would say, go and meet a fertility specialist. They will assess what is the degree of your endometriosis, what kind of treatment to be done, whether your tubes are open, what is the semen parameter of your husband. Depending on that, they will advise you what is a suitable treatment for you. Okay, laparoscopy is done. What did the result from the laparoscopy did they say? Your tube is open. What is the grade of your endometriosis? If it is something mild or minimal, mostly they would have told you to go with a simple treatment. But if it is grade 4 or plastered pelvis or frozen pelvis, what we tell, for that means they would have advised you IVF. After IVF, I can get what? Pregnant. Yes, that is the reason why they are doing for you. But you're definitely, your chance of, if it is a severe endometriosis and the ovaries and tubes are all, the anatomy is distorted, then definitely your chance of pregnancy is high with IVF. Another thing what I want to tell is, you have undergone laparoscopy and they would have treated, they've tried to release all your adhesions and try to bring it to as near normal anatomy as possible. This endometriosis is a recurring problem. Even if you give few months, but every month you get your period, the endometriosis bleeds there and endometriosis recurs. So in a woman who has severe endometriosis, I would always say go to a fertility specialist. They will do a laparoscopy. They'll make a plan for your future. Future in the sense for the pregnancy. You have to get pregnant at the earliest, because the more number of periods you get, the more quickly you will get your endometriosis back, and you're back to zero again. You will require, if you don't do any treatment for about 6 to 8 months, you would have again started with endometriosis and you may need another procedure. So I would say, please go to a fertility specialist, make a plan, and try for pregnancy at the earliest. A solution for endometriosis is you should not get periods. When you get pregnant, that time also you will not get your periods for about 9 months. Then afterwards you'll be lactating the baby for a minimum of 4 to 5 months or 6 months. You may not. Some people don't get periods for 1 year after they get deliver also. So this 1 to 1.5 year what you get is a cure for your endometriosis, or else that is pregnancy. Then slowly you will start getting your period. It will take another year or 2 years for this endometriosis to come back again. That time you would have conceived your second baby, means that is the cure. One is not to get periods. How do you not get periods? One is by your pregnancy. Second thing is you will have to stop the ovarian function. That is the second way of solution for this endometriosis. I have covered all the questions, I guess. Whatever questions were here, I have answered that. You're welcome. Somebody, I do not know from where you are, and if at all you require any help or assistance, we have about 18 centers all over India. You can contact one of the Oasis center. They will be able to help you. And our phone number is there at the end of the screen. So please make a note of it and call to that number. And if you want any assistance, we will be very glad to help you out. And anybody from Bengaluru is viewing this program, and you're interested in treatment with us, please do contact us at Oasis Fertility, HSR, second sector. Anything else is there? Any other questions? I would be, yes, Hyderabad Oasis. I'll be happy to answer. If all the questions are over, we will end this session.